Hi there. The topic that we are going to discuss is systemic response to injury and metabolic support. This is the second series in the lecture, and once I finish this part, I'll make a brief video which connects both these parts together so that you can see the whole thing from a bird's eye point of view. As the name suggests, what exactly does the cell do when there is a response to stress? As you are well aware, the DNA should open up, the mRNA comes and takes the sequence of the codons, and once it is ready, the mRNA then goes to the ribosomal RNA. The transfer RNA comes to get the individual amino acids and then starts creating a protein chain. All this occurs in the ribosome, and from the ribosome the protein is then moved into the endoplasmic reticulum. Now once the proteins are inside the endoplasmic reticulum, that's where they undergo folding, and they do so by the effect of calcium. During the period of stress, there is a reduced calcium level and these proteins get unfolded. If the ER senses this, they send distress signals to the nucleus to modulate the transcription process. Okay, transcription is the one where mRNA comes and takes the code from the DNA. If there is a prolonged unfolded protein response, it's indicative of cell damage, and this can lead to cell death. Under normal circumstances, the cell disposes of damaged organelles by autophagy process. But during hypoxia and stress, autophagy is induced to provide energy shifting from aerobic respiration to glycolysis, thus providing nutrients for energy production. The reactive oxygen and nitrogen species are highly reactive due to the nascent electron they carry in their outside orbit. They can easily oxidize the cell membrane of both the host and the pathogen. The host cells are usually protected from the ROS by antioxidant proteins. ROS are used not only in phagocytosis, but during a stress response can play an active role in adaptive immunity, activation of B and T cells, and even activation of the inflammasome. The heat shock proteins are intracellular proteins found in the cytoplasm, nucleus, mitochondria, and the endoplasmic reticulum. They are expressed mainly during burns, stress, and sepsis. They promote protein folding, and these HSPs target poorly folded proteins. Thus, during the protein unfolding response, HSPs start playing a role. So they can either exert a pro-inflammatory or anti-inflammatory effect. Now we compare the phenomena of apoptosis and necrotosis. Necrotosis or necrosis is a premature accidental death of cells by exposure to external factors like ischemia, burns, accident, inflammation. Whereas apoptosis is an energy-dependent organized process to clear senescent cells or old cells without promoting any inflammation around the cells. It can occur either through an intrinsic or extrinsic pathway, leading to increased mitochondrial membrane permeability, and finally leading to cell death. During sepsis, apoptosis affects the competence of the acquired immune system by specifically causing lymphocyte apoptosis. So when that cell line gets affected, that's when the acquired immune system gets defunct. There's a dysregulation of immunity, and because of the overwhelming sepsis and lack of immunity, it may lead to one cause of the death of the individual. I was having a conversation with one of my friends, an immunologist, and I told him I wanted to remember all the cytokines and all their functions. He started laughing and said, "Me being an immunologist, I can't remember it." And honestly, it doesn't make a difference because what is given in the textbook is overly simplified, whereas if you try to understand the reactions, it just goes beyond anybody. There's so many cross connections, it's too difficult to point out what's happening where. So thank God for all of that, what greatness He has made. So since it's an oversimplification, let's just look at the oversimplified portion. I'll just try to explain whatever I can and the mnemonics which I have made. If it makes some sense to you and something gets retained, great. If not, forget about it. So I'm going to give you the story of two guys. One is Mr. T and one is Mr. 13. Mr. T started training when he was 12 years of age, and he was training up to 35 years of age. Now, because of his training, he can keep boxing and he can last anywhere between 8 to 12 rounds without a problem. So Mr. T is always ready for fighting. Now Mr. 13 or Mr. Unlucky, he remembers that 4 plus 6 is equal to 10. So he's not unlucky anymore, so now he is Mr. 15. I know these sound lame, but this is a picturesque method, at least as far as I am concerned, to remember the effects of the cytokines. So these mediators of inflammation, that is TNF, IL-1, 2, 3, 5, 8 and 12, and also 12 and 18, are mainly inflammatory or pro-inflammatory, whereas 4, 6, 10, 13 and 15 are anti-inflammatory. TNF is one of the earliest responders after injury. It has two receptors, one which promote apoptosis and the other one which is anti-apoptosis. It induces shock and catabolism, promotes the amino acids becoming fuel in the liver, promotes insulin resistance. It induces coagulation, cell migration, and phagocytosis. There's another mnemonic to remember the functions of IL-1, 2, 3, 4 and 5. That's hot T-bone steak. IL-1, it induces fevers. It has similar physiological effects as TNF. But because it induces fever, it's also to be remembered as hot. IL-2, it promotes T cell proliferation, and therefore the T. Whereas IL-3, it promotes the bone marrow, therefore bone. Now there is a common question, why don't you transfuse blood after surgery for CA colon? This is because there is an attenuated protection after injury or major blood loss of IL-2 and IL-3, which leads to immunocompromise, basically because it regulates lymphocyte apoptosis. As far as 4 and 5 are concerned, the mnemonic is steak, one with a capital E, the other with a capital A. IL-4, it helps in T cell differentiation, B cell activation and production of IgE and IgG. And IgE, as you know, it mediates allergic and antihistaminic response. IL-4 also has a potent anti-inflammatory role. It can downregulate TNF, IL-1, 6 and 8. IL-5, the A, it promotes eosinophil proliferation and airway inflammation. And airway, along with all the mucous membrane and skin, they secrete IgA. So that's how one can remember the function of these mediators of inflammation. If you can remember the mnemonic, it's easy for you to ascertain the functions of the cytokines mentioned on the left. IL-6 is elicited by all the immunogenic cells. They basically inhibit TNF and IL-1, just as IL-10, even that inhibits TNF and IL-1. The difference of IL-6 is that it prolongs the activated neutrophil survival, therefore leading to a very damaging effect of the neutrophil. High levels of IL-6 are usually seen in cases of mortality. IL-8, remember figure of 8, it's a chemoattractant. That's what a figure of 8 does, isn't it? IL-12 is a pro-inflammatory cytokine. It usually works along with IL-2. IL-13 is only structurally similar to IL-4. It promotes B lymphocyte function. IL-15, as you remember the mnemonic, is mainly anti-inflammatory. Now IL-12, IL-18 and interferon gamma, they all work along with IL-2 and almost have similar kind of functions. As you can remember, IL-2 is important for the T cell activation. So all of these focus around the same point. Again, all of these are pro-inflammatory. Granulocyte macrophage colony stimulating factor, it promotes wound healing and inflammation. Again, it is pro-inflammatory. IL-21, very important for activation of natural killer cells, B and T cells. So again, it affects both the innate and also the adaptive immunity. IL-21, getting ready to fight as you're 21. HMGB1 we discussed in the earlier video that it's one of the main kind of prototypes of DAMP. So it induces sickness behavior, and if it remains elevated for a very high time, that means to say the degree and the duration of inflammation is very high, usually leads to mortality. Eicosanoids are the metabolites of arachidonic acid, and arachidonic acid is derived from the broken cell wall. There are two pathways, either cyclooxygenase producing prostaglandins and thromboxanes, and the lipooxygenase pathway producing leukotrienes and HETE. Now these products are generated upon stress, which are either by antitoxins, norepi-epiangiotensins, bradykinin, serotonin, acetylcholine and histamine. Actually, to be honest, you don't need to remember all this stuff. But basically remember that prostaglandins are good for chemotaxis, prostacyclins are anti-inflammatory, whereas leukotrienes have a very broad spectrum of action, having bronchoconstriction, vasoconstriction, leukocyte adherence, capillary leakage, and neutrophil activation. Omega-3 fatty acids, on the other hand, are anti-inflammatory by two mechanisms. First of all, they reduce the production of arachidonic acid, therefore eicosanoids are not produced. Second of all, they produce resolvin, which attenuates the inflammatory phenotypes of immune cells. Studies have shown that pre-op omega-3 fatty acid therapy can reduce the need for mechanical ventilation, decrease the hospital length of stay, and also decrease mortality with a good safety profile. We now look at two contents of the plasma contact system. One is the complement pathway, second is the kallikrein-kinin system. Both of these are active in the plasma, and after traumatic injury, the complement system gets activated. It binds and clears the host of all the pathogens, acting as the first line of defense. It also eliminates immune complexes and damaged dead cells. The major source of circulating complements is the liver. Likewise, prekallikrein is produced in the liver, gets cleaved to form bradykinin, and bradykinin is involved in vasodilatation, edema, capillary permeability, bronchoconstriction, and inhibition of gluconeogenesis. It also activates the pain pathway. Usually, it contributes to blood pressure, inflammation, coagulation, and pain response. Kallikrein-kinin system levels are increased in gram-negative sepsis, hypertension, hemorrhage, and tissue injury. Serotonin causes vasoconstriction, bronchoconstriction, and platelet aggregation. So similar to what happens in SIRS. Whereas histamine, its release occurs in hemorrhage, shock, trauma, and thermal injuries. Cells of both the innate and adaptive immunity are upregulated by histamine following injury. Histamine has different receptors, 4 of them which are shown, and you can see their various actions. During the process of cell injury, the cell membrane receptors and signaling pathways get activated, which ultimately leads to gene expression and regulation by the creation of proteins. This whole process occurs within 24 hours. Shown here are JAK-STAT and SOCS. JAK-STAT is a surface receptor. It binds to more than 60 different kinds of cytokines, and there is a dimerization of the receptor, basically type 1 and type 2, and these play a role in innate and adaptive immunity. Once the receptor gets activated, then there is a signal transducer and an activation of transcription. So in the end, there is production of proteins. At the same time the JAK-STAT gets activated, there is also a suppressor of cytokine signaling. So these molecules serve as a negative feedback for the cytokine receptors by terminating the action of JAK-STAT. Thus, the induction of SOCS occurs to the same signals that stimulate JAK-STAT. So there is some kind of effective control of JAK-STAT to make it a very fine control pathway. The next three receptors are the G protein coupled receptors, the TNF superfamily consisting of TNFR1 and 2, and the transforming growth factor beta. The G protein coupled receptors respond to adrenaline and serotonin, and finally they lead to production of IP3 and calcium release. During this activity there is a kinase stimulation which leads to gene transcription. TNFR1 promotes apoptosis, whereas TNFR2 is anti-apoptosis. TGF-beta is mainly needed for T cell homeostasis, so that everything goes on well with the T cell family. But at the same time, it can also inhibit immune response by regulating the maturation of dendritic cells and also activating macrophages, which express anti-inflammatory molecules. So it's on both sides of keeping the T cells growing up well, and also at the same time activating macrophages, which express anti-inflammatory molecules. So the previous slide was pretty silent, huh? Well, as we had seen in the earlier video, after trauma and either DAMP or infection and PAMP, there is going to be a key and lock hypothesis kind of a thing which I had mentioned. And once the receptors get stimulated, they are finally going to cause a change in transcription and translation. So proteins are going to be generated after gene expression. And this usually takes around 4 to 12 hours, but sometimes it can be prolonged for days to weeks. And those who have mortality have a higher degree and duration of this dysregulated immune response. While studying these patterns, they realized that a delayed clinical recovery or organ injury were not associated with any distinctive pattern of transcriptional change. So you can never predict who could get a delayed recovery and whose organ could be injured just by looking at these responses. But once the gene expression occurs, the process can be regulated at various stages, and at each stage it is possible to inactivate the mRNA or the protein to make these molecules non-functional. So it doesn't mean that just because stimulation has occurred with DAMP or PMP or the soluble pattern recognition receptors that nothing can be negated. There are a lot of checks in the way. And as I had mentioned earlier, everything what we are presenting right now is an oversimplification of this entire process. Now we look at the cell-mediated immune response. The platelets have no nucleus and their function in hemostasis is well known. But once the platelets get activated, they express and release pro-inflammatory adhesion molecules and cytokines, and also immunosuppressive factor TGF-beta. As far as the T cell and the lymphocytes are concerned, there is a T helper 1 cell response and T helper 2 cell response. The Th1 response is associated with lesser injuries, whereas that of Th2 is with greater injuries. The Th1 recognizes and kills intracellular pathogens, and it has pro-inflammatory functions, whereas Th2 response regulates the antibody production and also has an anti-inflammatory function. Dendritic cells are activated in response to damage signals that stimulate both innate and adaptive immunity. They can also up and down regulate the immune response by expression of chemokines. So it is a dual action. The eosinophils mainly have an anti-helminthing function. They are found in the lung and the GIT. The mast cells are located in the tissues. They release tumor necrosis factor. And as you remember, initially TNF is mainly pro-inflammatory. On activation, mast cells produce cytokines that lead to various effects and mainly immunocyte recruitment. The monocyte macrophage function. Monocytes are mononuclear phagocytes that circulate in the bloodstream, and they can at any point of time differentiate into macrophages, osteoclasts, and dendritic cells. The neutrophils are the first responders to injury and are potent mediators of acute inflammation. They have a very short half-life, but some inflammatory mediators can prolong their half-life, and that one is IL-6, as you remember that we discussed earlier. The vascular endothelium is normally anticoagulant because it secretes heparin sulfate, dermatan sulfate, plasminogen, protein S, tissue plasminogen activator, etc. But during sepsis, it has a procoagulant effect by reducing the production of all these factors. Now the endothelium and the neutrophil have their own interaction during inflammation, because during inflammation the endothelial cells start expressing surface adhesion factors which are called selectins. These are responsible for neutrophil endothelial reactions which promote adhesion, slow rolling, fast rolling, chemotaxis, permeability, and finally extravasation into the tissues. Chemokines, a small family of proteins, they are the ones which affect chemotaxis, and they also activate immune cells. They are released from many cells of the endothelium and even other inflammasomes. They have different receptors from the cytokines. Nitric oxide, again which is called as the endothelial derived relaxation factor, is released from the endothelial cells, maintaining smooth muscle relaxation by constant output. It reduces microthrombi by reducing platelet adhesion and aggregation. During sepsis, the nitric oxide levels increase, causing hypotension. Prostacyclins usually are vasodilators and they prevent platelet aggregation. But during sepsis, these actions are reduced, and thus, in the end, they have a procoagulant effect. Endothelins are very potent vasoconstrictors, 10 times more potent than AT2 or angiotensin 2. These are upregulated in response to lipopolysaccharide, hypotension, vasopressin, catecholamines, and anoxia. The platelet activating factor, especially during the phase of acute inflammation, is released by the immune cells. It can further activate neutrophils and platelets and increase the vascular permeability. In sepsis, there are reduced levels of PAF inhibitors, therefore augmenting the action of PAF. Natriuretic peptides, the brain and the atrial natriuretic peptide, are inhibitors of aldosterone secretion. Therefore, they prevent the reabsorption of salt and water. Now that we have come to this stage, after the video 1 and 2, let me use this slide to put together everything so that you get a bird's eye view of the whole situation. So we are trying to perceive the systemic response to injury and trauma. First of all, we saw a range from SIRS to septic shock, the 4 different definitions that were given to us. And we realized how exactly does the human body detect cellular injury. It could be either a damage associated molecular pattern or a pathogen associated molecular pattern. So one of these two start telling the body that, see, there is an injury. The DAMP is damage associated. You got to damage the tissues, so either it has to be HMGB1, that's high mobility group B1 protein, the extracellular matrix, or even the mitochondrial proteins which can act as a DAMP. The DAMPs act like keys and they have to fit in a lock. And so the receptors are the pattern recognition receptors. There are 4 different kinds of receptors which I mentioned earlier. So once the key fits on the lock, that means the stimulus has come to the receptor. These will now start acting, and furthermore there is going to be either a gene production or there is going to be stimulation of gene expression. When these DAMPs and PAMPs react with the PRRs, these molecules are going to become all the more soluble. So these soluble patterns are going to be recognized by certain molecules known as the pentaxtrins, also known as the acute phase reactants. So these molecules suddenly increase in number to amplify the response between the DAMP, PAMP and the PRR. Now once there is a recognition of a pattern, there is going to be a receptor signaling, and this receptor is both for the TLRs and also for the inflammasomes. So this amplifies the actions at the level of the receptor and also gets all the inflammatory cells active. So once this happens, there is going to be more cytokine release and the receptors are going to be all the more receptive. So it means to say that a simple reaction caused by creating a DAMP is now going to get amplified. So if there is a very small stimulation, it's going to be only a local response, whereas if it's a very strong stimulation, it's going to be a systemic response, all depending on the degree of the damage. The CNS also regulates the SIRS by virtue of the hormonal interplay between the HPA axis and the catecholamines. There are many other hormones also which we have seen which come into play. For example, insulin and aldosterone and things mentioned earlier. Now once there is an inflammation, what does the cell do? How does it respond? As we have seen, there are various patterns that occur because either of change of calcium, there is an unfolded protein response, autophagy, that is just trying to take off certain organelles which are in disuse or old to provide energy, and this could be accelerated in cases of trauma. There could be a heat shock protein response which mainly targets the unfolded proteins. The reactive oxygen species could come out, either apoptosis or necrotosis depending on the degree of damage that is being done to a cell. So this is how a cell will finally respond when it is facing a traumatic situation. We saw the various mediators of inflammation, the various cytokines, and I described them well in the slide, so I don't want to go over them again. Coming to the cellular response to injury. So if a cell gets stressed out, it will do what is described on top. Whereas what does a cell do now to respond to any kind of injury? There is going to be stimulation of certain receptors, as you had seen, the JAK-STAT, and just the one opposite to it, that is the SOCS. Okay, so both of these work hand in hand at the same time, which is JAK-STAT is up regulation and SOCS tries to down regulate JAK-STAT. There's also the GPCR, that's the G protein coupled receptor. So all these receptors in the end will try to cause gene expression along with the TNF receptor, that is the TNF superfamily receptor, and the transforming growth factor beta receptor. They try to cause gene expression in the hope of secreting proteins which are either trying to build the cell or creating enzymes or trying to turn things around. So the transcriptional and translation changes occur due to the cellular response to injury. Coming to the cell-mediated immune response, this is how the immune cells, for example, the eosinophils, the neutrophils, the macrophages, the dendritic cells, how do they exactly respond? So basically these inflammasomes can either downregulate or upregulate the inflammation, as you have seen. They could secrete so many chemokines and cytokines. So that's their basic function. And in the end, the last thing that we looked about is the endothelial mediated immune response. So all these immune cells are there inside your bloodstream, And once they do get activated, what does the endothelium do to them? It tries to basically get them out of the system, because that's where they have to go. They have to go to the tissues. At the same time, you'll observe that during sepsis or during trauma, the whole thing now shifts from an anticoagulant to a procoagulant effect. So there is more of chemotaxis, more of platelet aggregation, more of microthrombus formation. All this trying to show you that during a traumatic injury or even during a sepsis, one tends to be more procoagulant than anticoagulant. So basically, as was rightly said earlier, and I'm quoting the textbook, that it depends on the degree of inflammation. If the inflammation is less, the response is less, everything is goody-goody. But if the response is prolonged and it's very severe, it usually ends up in death. Thanks for watching the video, and please like, comment, subscribe, email me.